Jens Lundgren, University of Copenhagen. I'm an MD, have been a specialist in infectious diseases, have been involved with HIV care since 1987, since I was a young doctor. My current position is that I'm professor of medicine at the university and a practicing clinician at the main referral hospital in Copenhagen that follows more than 2,000 HIV patients, and have a pretty large research group as well, Copenhagen HIV program or CHIP that I oversee as well. My involvement with the conference was that I was invited to give a talk on the research methodology that we have used to provide evidence for that informs on care of patients, namely observational studies. And I think I was invited because of the fact that in the contemporary discussion, observational studies have a pretty important place, although we would like to see randomized trials being the most important applied research methodology, but it isn't. So as a supplement, we use observational research data. And my talk focused on how this research methodology can be used, but also to some extent and sometimes actually misused in guiding evidence on how best to treat HIV patients. So that was the theme of my talk, and I assume that's why I was invited. My key messages is that we need large, quality assured observational studies to inform the best way of handling HIV patients. We need to make sure we don't overinterpret the data coming from these sorts of research at the same time. And more specifically, in the discussion on when to start ART, which was the example that I used, that there is some issues at the moment that we are faced with in terms of how different panels, guideline panels, are using the evidence available. Well, it depends on there are several different questions and important questions. I think in my own context from Europe, the largest public health issue that is remaining is the fact that we have still not been able to come up with a sufficiently good testing strategy to diagnose people so they enter care early on in the course of the HIV disease. So as a consequence, we see many patients enter care too late. That's really the major bottleneck that we haven't resolved, and I have the impression that that's equally a problem here as well, because it leaves people with two issues, or the area with two major issues. The first one is that people enter care too late, which we know is unhealthy for them. Treatment works, but it would work more optimally had they entered care a little earlier. And equally, that people who's not aware of the HIV diagnosis obviously can be the source of onward transmission. Oh, that's a very personal question. I mean, I think we set up many years ago a study called the DAD study that was aimed to understand longer-term consequences, adverse drug reactions to antiviral treatment, and we identified issues around cardiovascular disease, and we explained why they were there, and we have now seen them disappear as a consequence of our efforts and the effort of the field. So that I'm pretty proud of. I'm pretty proud of the fact that I was involved with the SMART study demonstrated that what was considered until 2006 to be the most appropriate way of using treatment, namely intermittently, we showed in the SMART study that was an unsafe way of using antiviral treatment. As a consequence, people, once they start on therapy, they should be maintained on therapy without interruptions. Early on in the disease, we were able to document the extent of benefit of treatment on a population level, which was important for policymakers in Europe to have that data to invest in treatment at the time. I guess the fourth one is at the time early on after ART was introduced, there was this discussion about whether treatment and the recovery of the immune system left a hole in the immune system or not, whether you can totally repair the immune deficiency that untreated HIV, severe HIV disease allowed different diseases to develop, whether those holes could be fixed if you saw an increase in CD4 cells. And we're able to show that indeed those holes can be fixed by antiviral treatment. Another important observation that led to changes in our approach to handling patients that recovers from immune deficiency. It's interesting. I think touches on something that I'm sometimes missing at the more sort of hardcore medical conferences, namely this multidisciplinary approach. There's many stakeholders involved in the response to treatment of HIV. That's true everywhere, but to actually see a conference that integrates people, that works in the different aspects of HIV care and optimizing it, I'm pretty impressed with. So that's good, and that's clearly something that I think needs to be continued, because the challenges that we're faced with at the moment requires a multidisciplinary sort of response.